Good morning. My name is Aditya Vedantam. Thank you for giving me the opportunity to talk. I'm one of the spine fellows here at the University of Miami. Today, I'll be talking about the utility of spinal cord diffusion tensor imaging, or DTI, in degenerative cervical myelopathy. I have no relevant disclosures. This talk will be in three sections. In the first section, I'll focus on the background of spinal cord diffusion tensor imaging and how we process the images. And then I'll talk about how DTI can be applied in two specific situations. One is cervical stenosis without myelopathy, and the second one is degenerative cervical myelopathy and outcome prediction. So diffusion-weighted imaging or diffusion imaging is an MR technique that measures the diffusion of water molecules in tissues. We know that when the water molecules are unrestricted, they have isotropic diffusion. The diffusion can happen in any direction. But in axons, the diffusion is restricted by the axonal membranes and the myelin sheaths, so it happens more in one direction than another. So this is anisotropic diffusion. Now we use diffusion-weighted imaging for stroke to differentiate pathological tissue and non-pathological tissue. But diffusion tensor imaging adds another component to diffusion-weighted imaging. It adds direction. So it measures the direction in which water molecules diffuse. And we know in axons, they're going to diffuse preferentially along the length of the axon. So they diffuse parallel to the axon. This kind of anisotropic diffusion is captured by DTI. And there are several metrics that are used when you use DTI. And one of them, which you're going to see in a lot of the studies, is fractional anisotropy, or FA. So this value ranges from 0 to 1. And a value that is closer to 1 usually indicates an intact axon. So like 0.7 or 0.8 is usually indicative of an intact axon. When that axon is damaged, say the axonal membranes are injured or there's some demyelination, then water molecules can diffuse perpendicular to the axon, and the fractional anisotropy, or FA, reduces. So there are other DTI metrics, but fractional anisotropy, or FA, is a common one that is used when you talk about spinal cord DTI. So really, DTI is able to provide some kind of estimate of microstructural changes that are happening within the spinal cord. The early studies used animal models. They correlated histology with the ex vivo DTI, and there have been fairly strong correlations with different DTI metrics and different types of neural injury. So if it's axonal injury, then kind of this parallel vector was correlated well. If it was demyelination, then the perpendicular vector. So overall, the correlation between histology and DTI metrics is fairly strong and has been shown in animal models, several animal models previously. So in this review, you see they looked at different types of DTI metrics. There's axial diffusivity, radial, mean, and then the fractional anisotropy I spoke about. And the profile of these metrics vary with the type of injury you're going to see. So if it's axonal injury, this is the profile. If it's demyelination, it's this one. If it's a combination, you may see this kind of profile of the metrics. So overall, I think DTI is particularly useful in the spinal cord, where it's not feasible to get tissue for pathology. And so it provides a technique to non-invasively evaluate microstructure so that it can be used as a biomarker. So how do we get a DTI scan? You actually just use your regular MRI that you use for clinical use. There's a head and neck coil that we use for patients getting cervical MRIs. The sequence just has to be programmed into the scan, and you can tack it on to a conventional MRI sequence. Adds about 12 minutes for the cervical spine. Most of the work is done after the scan is obtained, so post-processing. So there are a variety of software packages available, and these will process the image and they will spit out the DTI metrics. What you can do is you can draw a region of interest around the spinal cord, and that region of interest will capture all the voxels within the spinal cord, and you get the metrics. Recently, a new software package came out, the Spinal Cord Toolbox, and this is able to co-register a template to the spinal cord, and you are able to actually get DTI metrics for the individual white matter tracts. So different ways to process these images, but they're fairly easy to obtain once they're programmed into the scanner. So when I looked at this and started getting into this field some years ago, we looked at just healthy subjects with no evidence of disease. And we got just cervical spinal cord DTI images for these subjects. And what we found was actually the older subjects had a lower FA, or fractional anisotropy, in their cervical spinal cord as compared to younger subjects. And this was despite their T2 MRI looking normal, no evidence of myelomalacia, no evidence of significant stenosis. And so these microstructural changes were captured by DTI, and this correlates well with what we are seeing in histopathology. So in histopathology, we know that patients get neuronal loss, anterior horn cell loss, apoptosis with age, and the DTI metrics seem to correlate with what we are seeing in that. The other important conclusion of this study was the importance of age-matched controls. And so we see that DTI metrics are age-dependent, and so when you're comparing cases and controls, you want them to be of similar age. Let me just see, I hope this is in presentation mode. Let me just see one thing. Okay. So DTI metrics, so DTI is superior to conventional MRI. Here in a patient with stenosis, we're seeing, when you measure the DTI metrics at C5-6, which is the worst level of stenosis, you get an FA value of 0.47. At a non-stenotic segment above this, at C2-3, you see an FA value of 0.65. So DTI is able to give you that kind of quantitative measure, and it removes some of the subjectivity you see when you talk about mild stenosis, moderate stenosis. And this objective measure, I think, is useful in that it actually tells you about what's happening in the spinal cord. So with this background, I'm just going to switch to the second section of the talk, and I'll be talking about cervical stenosis without myelopathy. This is an example of a patient we saw here at University of Miami a couple of months ago. It's a 71-year-old who came in with dizziness and headaches. He had no arm symptoms, no sign of myelopathy on exam. And when we saw him in 2019, he was relatively asymptomatic, and we told him no surgery, come back in a year with a repeat scan. So he comes back in a year, his scan shows similar stenosis, perhaps a little worse, again, no symptoms or signs. And so the question in this kind of patient is, and he himself asked us, the stenosis has been going on for this long, is my spinal cord already damaged? What's the point in waiting? Should we get surgery done urgently? So what answers do we have for these kinds of patients? We're seeing more and more of them with the increasing use of conventional MRI for a lot of our patients. So the best data actually comes from Europe. This was a study in almost 200 patients. They looked at these patients prospectively. These were patients with cervical stenosis who did not have signs or symptoms of myelopathy. And when they followed them up, what they found was approximately 20% of them developed myelopathy over time. And they did find a few predictors. If they already had evidence of neural compression, like radiculopathy, then they were likely to progress to myelopathy. If they had abnormal SSCPs and MEPs, it's not something we do routinely as an outpatient. And then some patients actually had T2 cord signal change, like this patient here from the paper had a C5-6 stenosis with cord signal change, but was asymptomatic. So we have a few predictors of which patients are going to progress, but the data is not very strong. And we know that there is a need for better tools for cervical myelopathy. Often we find a patient who has severe stenosis and mild symptoms, then we have a patient with mild stenosis but very symptomatic. A lot of patients are getting conventional MRI for neck pain, dizziness, and the cervical stenosis that we find is often incidental. We can't pick up any clinical signs. This study by John Rhee and his team looked at approximately 40 patients with cervical myelopathy, and about 20% of them had no signs, so no hyperreflexia, no Hoffman's. And so sometimes the diagnosis can be challenging. It's only subjective symptoms, history, and we really don't have objective findings. The AO spine guidelines kind of echo this issue. When we talk about cervical spinal cord compression without symptoms of myelopathy, the quality of evidence is low and the strength of recommendations is weak. So really additional tools to objectively define spinal cord pathology may be able to help us in these patients. So how can DTI help? The same European group that did that initial MRI study looked at patients with asymptomatic cervical stenosis. So they studied 3 groups of patients. They had patients that were healthy controls, they had asymptomatic cord compression, and they had patients with symptomatic myelopathy. And what they found was the Dti metrics here in red outperformed conventional MRI measures, spinal cord diameter, spinal cord area, presence of hyperintensity, and was able to better discriminate these two groups, the asymptomatic and the symptomatic. This is actually a figure from that study. So you see this patient A with stenosis at C5-6, the FA value is low, 0.42. So you suspect that this patient has more axonal injury. This patient B had very similar stenosis at C4-5, but the FA value was higher at 0.707. And so in this paper, the patient with the higher FA, as expected, was the asymptomatic patient, and the patient with the lower FA was the symptomatic patient. So really providing some kind of objective measure to discriminate these kinds of patients and help us better make clinical decisions for them. This was a study from UCLA where they looked at it a little differently. Here they got longitudinal assessments. So they got serial MRI scans and DTI scans for patients over time. There were 66 patients. And what they found was when the FA drops by about 0.03, the MJOA decreased by approximately 1 point. So there was a link between structure and function. And more importantly, this study highlighted the reproducibility of MR measurements. So the coefficient of variance for DTI metrics like FA and MD were comparable to what you would use for TOG ratio or canal diameter. So there is some evidence that these measurements are reproducible. There is some variance, but that variance is not different from what we would use when we used conventional MRI measures. And lastly, this study from Canada looked at 26 patients with cervical stenosis without myelopathy, and they tried to see how they could monitor these patients. So what they did was they followed these patients up every 6 months, and they got quantitative MRI as an objective measure, and they also looked at subjective symptoms. So many times these patients come to us, they have subjective symptoms, numbness in their fingers, some dexterity issues, and on clinical exam, we're really not able to pick up anything, especially something done in the clinic. And so they used a combination of these two, subjective and objective worsening, to make a decision on whether these patients should undergo surgery or should we continue to just follow them up. I think the finding in this study was that the quantitative MRI correlated well with the subjective worsening. So there was an objective measure that they were able to elicit to explain some of the subjective symptoms these patients had. And so I think it is a useful adjunct to detect subtle changes. There's definitely more work that needs to be done, but this is one of those tools that we could use, especially if we got it routinely in patients undergoing cervical spine MRIs. So at the conclusion of this segment, I just wanted to highlight that there is limited data on the risk of progression of myelopathy in patients with asymptomatic cervical stenosis. And it is superior to conventional MRI. It gives us more information. The information is quantitative. And perhaps in these patients, we can identify those who are going to deteriorate earlier, as well as perhaps even make early diagnosis of spinal cord damage or myelopathy. So I'll move on to the last section of the talk. This is going to focus on using DTI in patients with established cervical myelopathy. So in this patient, for example, the diagnosis is clear, the classic symptoms and signs of cervical myelopathy. And this patient also has cord compression with signal change. And so in a patient like this, when we counsel them for surgery, the question is, what is the likelihood this patient is going to regain their lost function? What component of this kind of spinal cord injury is reversible? When I looked at this some years ago, I tried to see what the signal change is all about and how it was described in several studies. And what I found was there was a lot of variability as to how signal change is described in cervical myelopathy. Some studies looked at the length of the signal change. Does it go through a few segments or does it go multiple segments? Other studies looked at qualitatively. Is it diffuse and fuzzy? Is it sharp and punctate? And then there's other qualitative descriptions, the snake eye appearance when in distal amyotrophic type of cervical myelopathy. So just a lot of variability, and there's no definite classification system or objective way to look at this signal change. So does it make a difference at all? We looked at approximately 200 patients with cervical myelopathy undergoing central corpectomy. And what we found was the sharp punctate type of hyperintensity, as well as T1 hyperintensity, something we don't see often, were really the strongest negative prognosticators. So patients with these two kinds of signal change were least likely to achieve a Newdick grade of 0 or 1 at follow-up. So we have some predictors of, MR predictors of outcome. But interestingly, the fuzzy type is actually the most common type we all see, and that doesn't have very good prognostic value. What do we talk about when we talk about this T2 signal change? We tell patients the spinal cord is bruised, there's myelomalacia. This study from Japan looked at histology in those patients with signal change. And what you see is that the T2 hyperintensity is just not specific. It can reflect severe or mild injury, and it doesn't really reliably differentiate reversible or irreversible spinal cord damage. So can DTI help in determining this, the degree of spinal cord damage? The early studies looked at fractional anisotropy at the level of maximum stenosis. So here's a patient with C5-6 stenosis. And the early studies showed that the FA at this level, at C5-6, correlated with the preoperative MJOA. So not really predicting outcome, but actually showing some link between the structural changes you're seeing on the preoperative MRI and the preoperative MJOA. When we looked at this in a prospective study, we got 27 patients with cervical myelopathy, and we obtained Dti metrics at the level of stenosis here at in this patient at C6-7. And what we found was it did correlate again with the preoperative MJOA, but it also was able to correlate with outcome, the change in MJOA at 3 months and at 12 months. So it does have some predictive value, and this outperformed what we could predict with conventional MRI. Other authors have taken it in a different direction. What we found was when you try to measure Dti metrics at the level of stenosis, sometimes the spinal cord is so compressed, you're going to get a lot of artifact. In other patients, there's a little hardware there, and so you're not able to get a good MRI image at that level. So this Swiss group looked at Dti metrics above the level of stenosis, here at C2-3, and they were trying to capture this Wallerian degeneration, the retrograde degeneration that happens with chronic spinal cord injury. And they found that actually they were able to capture atrophy of the white matter and gray matter at C2-3, and the Dti metrics at this level correlated with the light touch sensation and other functional measures. So there is, again, this looks normal on conventional MRI at this level, but the Dti changes here do seem to have some functional relevance in these patients. And lastly, the study that came out recently looked at post-operative Dti. These images post-operatively are sometimes challenging, especially if patients have a lot of hardware. But these authors were able to get these scans in a small group of patients. And here the post-operative FA is in orange and the preoperative FA is in blue. And you see the post-operative FA was higher than the preoperative FA, perhaps indicating that there is some form of reorganization or some form of microstructural change that happens post-operatively. And this seemed to correlate with improved hand function in these patients. So a recent systematic review looked at about 9 studies. There have been several more since then. And you see in most of the studies, the correlation between structure and function preoperatively is strong. But for outcome prediction, there's still more work that needs to be done. I think a few studies like ours did show some predictive value, but more are needed. Spinal cord Dti has several limitations. It's different from brain Dti because the ratio of the neural tissue to the surrounding structures is flipped. There's just a small spinal cord and there's so much bone around it. So a lot of artifact and scanning parameters that need to be optimized. A lot of the studies use group statistics. So if you have one patient in clinic who has a FA value of 0.5, what do you do with that? That needs to be teased out some more. And I think overall, Dti may be useful as a part of a predictive model. So you use age, duration of symptoms, severity of disease, plus Dti may make that predictive model more accurate. So I'd like to conclude here with this talk, just to highlight that there are some limitations with conventional MRI in specific conditions with cervical myelopathy. Conventional MRI is great to plan surgery and to determine where the stenosis is and whether it's anterior or posterior, but actually evaluating the spinal cord and how it's damaged, I think it's limited. Dti is non-invasive, and I think it's ideally suited for spinal cord where it's not feasible to get tissue for analysis. And I think the use of Dti in a smart way can potentially aid clinical decision-making in these patients. Obviously, this work is collaborated. I collaborated with several other investigators and mentors. I spent time at Medical College of Wisconsin before residency working on Dti, and then faculty from my med school as well as residency helped to further improve my skills and knowledge in the subject. Thank you for your attention. Thanks.
Hey, Dti.
Yep.
I was thinking, and I was wondering if, do you think there was any case to be made for having like a screening cervical MRI at a certain age group, like, you know, we do colonoscopies? Do you think the prevalence is high enough so that we should be doing just screening MRIs and anyone with subtle symptoms, or obviously if they have symptoms, but just asymptomatic?
I don't know. I think if they come to your attention, it's what the Japanese have done screening MRIs in a large population, and they found, you know, a lot of them, many patients even had T2 hyperintensity in the cord, but were asymptomatic. I think, you know, to actually just do the MRIs, conventional MRI probably doesn't add much. I think if you're going to do it where you're going to follow them up serially with another MRI, maybe at 6 months and 1 year, then something like DTI can give you that quantitative measure that may help you counsel the patient as to getting surgery earlier. So I think there it has some value, but it's just screening with a completely asymptomatic patient. I would say probably the benefit is not very high.
I was thinking like from a public health perspective, but I do think that's it. Appreciate the talk. Thank you so much, man.
Thanks. Okay, Will.
Okay, can you hear me?
Yep.
Okay. I'm William Steele. I'm going to be talking to y'all about surgical planning and how to take that from the clinic to the OR. This is mainly applying to spinal patients, in particular spinal deformity patients, but the argument could be made to extend it to all fusion patients. This is my disclosures. So what we're going to be talking about today: why plan the surgical procedure, how to plan the surgical procedure, and then how to execute the surgical plan. So why to plan the surgical procedure? Well, it's about spinal balance, right? Adverse health outcomes highly correlate with increased positive sagittal balance. Surgeries that correct neural impingement or spinal instability, but still cause sagittal imbalance, will usually give a bad result. And we know that all fusions have the potential to create focal deformities. So why plan the surgical procedure? Well, it started with this paper from 2005. And what they were able to show is that of 352 patients, all had positive sagittal balance. The severity of their symptoms increased in a linear fashion with progressive positive sagittal balance. And what was impressive with this was that all health-related quality of life measures worsened as the C7 plumb line deviation increased. And they also noted that kyphosis was very poorly tolerated in the lumbar spine. So keeping with why plan the surgical procedure, well, life itself is a kyphosing event, as you can see from A to B to C here. We all start out balanced, and then as our spines degenerate, we progressively kyphose, and there's several compensatory mechanisms, whether that's thoracic hypokyphosis, pelvic retroversion, hip extension, knee flexion. All of these things help compensate to bring our cone of economy, help to bring our head back over our pelvis, back over our feet, to be in the most ergonomic position, okay? As this progresses, we have, our patients will come to us with problems with difficulties with gaze, hip and knee flexion contractures, fatigue, significant pain, disability. So another reason why we should be planning our surgical procedures, in particular fusion procedures, is because you can't eyeball a scoliosis x-ray, okay? A scoliosis x-ray is a 36-inch cassette tape film that includes the femoral heads up to the top of the cervical spine. And unfortunately, if you just draw a line from C7 or C2 and you follow that down to the sacrum, that alone is not always enough. And the reason why is because people compensate for their sagittal imbalance, right? So for any given structural deformity, there will be a certain degree of pelvic retroversion, which will compensate for this deformity. If you look here on the bottom left, everyone who looked at this x-ray would say this patient definitely is sagittally imbalanced. But then you look in the middle and you can see as the sacrum becomes more vertical, and especially in relation to the femoral head axis, you can see that as it comes more forward, there's more pelvic retroversion, to where in the middle picture, you think that there's mild imbalance, and in the right, you would say, oh, look, this patient doesn't have any imbalance, when in fact, they have a very high pelvic tilt. And then in the schematic to the right, you can see that not only is as the imbalance progresses, do we have pelvic retroversion, but then we also have things more distal with hip extension, thoracic and knee flexion. And you can also get thoracic hypokyphosis with this as well. And another element that also contributes to this is that scoliosis x-rays have to be performed correctly. So in these two examples, you have dramatically different SVAs, and it's all due to not executing the scoliosis x-ray appropriately. So when you start planning your procedure, you need to make sure that you have a good relationship with the radiology department to ensure that these patients are straightening their legs, that you are getting an accurate reading. And if you're not, then in the comment section of the results, they need to say something along the lines of patient was unable to stand, therefore you know that your scoliosis x-rays are likely unreliable. And I will say that there are options to include full body x-rays that include the feet and legs to be able to evaluate the entire body with surgical planning. So another issue is that one of the goals of the procedure is to achieve a good fusion. And even when you achieve a fusion, you can still have a poor clinical outcome. All right, so sometimes, in this paper, they found that 30% of lumbar fusion still had a poor clinical outcome. And they found that this was mostly related to pelvic parameters with decreased sacral slope, increased pelvic tilt, and decreased lumbar lordosis. And so this is something we would view as a successful surgery, but the outcome is far from that. So another reason to plan is that failure to plan and failure to execute your plan appropriately is costly, right? So proximal junctional failure, and this is in relation to spinal deformity patients, but like I said, you can make the argument for all spinal fusion patients. But at the UCSF, they found that a proximal junctional failure costs approximately $55,000 per case, right? So this adds up. And another thing to consider is that everyone's spine is different, right? We see this in clinic. We realize that the lumbar lordosis of one patient isn't necessarily going to be the lumbar lordosis needed of another patient. And this was described by Ruz Lee. And we typically describe these patients as either type 1, type 2, when they have a low-grade pelvic incidence, which then influences their sacral slope, which then influences their relative lumbar lordosis. And to differentiate that between the types 3 and 4. So if you're going in and you're going to fuse a patient with a type 4, you would want to have more lordosis. You would want to achieve more lordosis per level, right, than you would with someone who has a type 1 spine. Another thing that has come to light relatively recently is that the amount of correction per patient is different based on their age, right? And we intuitively understand this, but the amount of correction that's needed in someone who's greater than 70 years of age is not the same as someone who's going to be 35 years of age. And you can see this here from the different SVAs based on the radiographic thresholds for their ODIs, right? So why would you put the same implant in a 70-year-old that you would in a 35-year-old when you know that the amount of correction that each one needs isn't the same? And most importantly, we realize that outcomes matter, right? I mean, this is one of the strongest reasons to make sure that you plan, because a large percentage of patients can still remain sagittally malaligned after surgery. And we know that sagittal malalignment is one of the most common predictors of poor clinical outcome. And this is a paper looking at 1 to 3 level degen constructs. And if the patient remains imbalanced with a PIL mismatch of greater than 10 degrees, their risk of developing adjacent segment disease was 10 times more likely. And finally, when we fuse these patients, we're fusing them for life, right? So this procedure has to have significant long-lasting effects, and then there's certain implications from that. So there's few things in neurosurgery outside of these fusions where the goal is several decades long, right? And then on top of that, adults are kind of outliving what was traditionally defined for surgical durability. So all of that explains why we should be planning the surgical procedure. Now I'm going to go into how to plan the surgical procedure, what you should be looking for if you're going to plan the surgical procedure. And this paper, using linear regression for the disability thresholds, they found that the three biggest parameters to follow were an SVA of less than 5, pelvic tilt less than 20 degrees, and then a PIL mismatch plus or minus 10 degrees. So that's overall what we're looking at. So just a quick refresher, pelvic incidence is a fixed value. It relates how the sacrum fits to the pelvis. And it's specifically the angle perpendicular to the sacral end plate, and that line extended to the femoral head axis. The range is anywhere between 35 to 85, and everyone has a different pelvic incidence, okay? And in general, the pelvic incidence should be within 10 degrees of the lumbar lordosis. Sacral slope is the angle between the horizontal line and the upper sacral end plate. This changes. It's usually between 30 and 50 degrees. And it is important because the sacral slope plus the pelvic tilt equals the pelvic incidence, which we know is a fixed value. And we know that pelvic tilt is how patients compensate for their sagittal imbalance. Pelvic tilt is an angle between the vertical line and the midpoint of the sacral end plate to the femoral head axis. Its mean value is 13 degrees. We usually like it to be less than 20 degrees, and it denotes the spatial orientation of the pelvis. So as someone retroverts their pelvis, the sacrum becomes more vertical, the femoral heads relatively move in front, and that's kind of a tip-off that the patient is compensating for their sagittal imbalance. So just to reiterate, C7 plumb line, less than 5 centimeters, pelvic tilt, less than 20 degrees, and a PIL mismatch of 10 degrees is the overall. And then this all falls under the SRS Schwab classification, as you can see here, where you look at coronal curve types less than 30 degrees, and then you have sagittal modifiers looking at PIL mismatch, SVA, and pelvic tilt. And I include this slide in here to say that this is to say that this is not a perfect system. It is a work in progress. There's still other systems being developed. And what I mentioned here is the Global Alignment and Proportion Score, where they're trying to find a way to prevent mechanical complications, particularly in adult spinal deformity. And there's the GAP score also isn't perfect. And there's been recent papers that have shown that hasn't been able to be reproduced as well. So now, how to plan the surgical procedure? Well, there's several different options. There's software that you can download for free, and the one that I'm most familiar with is SurgiMap, and it's a universal image viewer. It has an encrypted database that is HIPAA compliant, and what's special about this is that you're able to simulate the cases, whether it's an osteotomy or a hyperlordotic graft. You can actually dial that in to your cassette and simulate the correction, and they monitor how if you've achieved the correction that you need. NuVasive also has NuvaMap, which is very similar, except it's attached to the NVM5 software, which allows you to intraoperatively monitor your correction to see how much more you need if you need to perform an additional osteotomy and so forth. So I just want to walk through exactly how this works. You download the app, you log in, you go to your database, you import the images. You can do this whether a screenshot, DICOM, JPEG, then you measure those things and you can simulate. So this is what it looks like. You log in, this is importing the images. You find your images, you follow their workflow to make the appropriate measurements. It spits out these values for you. This is what it ultimately looks like. You can see here that it lists the pelvic tilt, pelvic incidence, and the other parameters. And all you do is just follow this in a stepwise fashion, okay? And this is, if you look on the right here, you can then draw in the type of osteotomy that you want. You hit simulate, and it actually breaks the image and shows you what your correction will look like. And this is detailing this again. You can see here in the bottom left, you draw in your 2 lines, you hit simulate, and now you've applied your osteotomy. And so what are you left with? You have this measuring table where you can see the pre-op and post-op. The pre-op obviously has a lot of red, and post-op has a lot of green. So let me just walk y'all through this. So you hit the, you upload the images, you go down, you find the femoral heads, you draw out the femoral heads, and it takes the line between those 2 femoral heads, you draw the sacral end plate, then you go up, you find L1, you draw that end plate, and then now you have your lumbar lordosis. If you're doing a procedure that goes up to the thoracic spine, you then dial in the T1 end plate as well as the C2 end plate, and then you have the schematic which represents every single vertebra. It gives you your values here, and then you can come down to the bottom left, and you can see where the patient is particularly malaligned. And then after you have this completed, then you can see where you need to make your correction, how much correction you need to make. And let me see. So then you can simulate the operative strategy. And so here they can compensate for the pelvic tilt. As you see here, rotating, you get the pelvic tilt to a more normal range. If you want to do something like a PSO, you click the PSO, you simulate it, and you see it break right there. And then you can see on the bottom left if you achieved your necessary correction. Nuvamap also has this. It's very similar, except you're able to, in real time, monitor your correction. Okay, so now that you know how do you execute the surgical plan? You can do this through several ways. We have different osteotomies that are more aggressive for more correction as needed. You have interbody implants. The robotic systems allow for planning of your pedicle screws. And then there's also patient-specific rods based off of your plan that if you lay them in and everything lines up perfectly, you know you've achieved your correction. This is the Schwab classification for the different osteotomies that go progressively more, for progressively more correction. They're now coming out with different cages. This is an expandable cage where you can dial in the exact lordosis that you need based off of your preoperative planning. Dr. Yurikoff and I used this last week in a prone lateral ACR, and we were able to monitor in real time how much correction we had and how much more we needed. This can be applied to the cervical spine as well as the thoracolumbar spine. And you can monitor this as you go. With robotics, in particular, I'm discussing Mazor, but all of the systems have this. You're able to plan your construct with the software. And you can do this off a preoperative CT scan. Let me just show the video here. You go in, you place the pedicle screw, you can get the correct orientation. They have true AP lateral axial views. You're also able to scroll down the pedicles to ensure that your pedicle screws are exactly where they need to be. You can dial in how the diameter and length, and all of this can be done preoperatively. So when you show up on the operative day, all of your screws are already on the back table, loaded up, ready to go, and there's no guesswork. You can also play with your screw cadence to ensure that your rod passage is appropriate. And then you can also, for MIS capabilities, you can add towers on to plan exactly where your skin incisions would be. How am I doing? Hurry up a little bit. And then once you have your plan, all you have to do then is start the robotic arm. The robotic arm comes down, and then you're working in exactly where you thought you were working. All of this can be navigated in real time, and it allows you to basically focus on executing your plan and not have to worry about either screw size, screw length, things like that. The advantages are high pedicle screw accuracy rates, lower intraoperative revisions, and so forth. Lastly, I wanted to just discuss patient-specific rods. This is a company that I've used in the past, and we've published some papers together. And the group has biomedical engineers that can take your scoliosis X-rays, develop the images, or develop the plan on their own and send it to you for approval, or you can create the plan yourself. And then they have AI and analytics that track if you were able to achieve the correction, what long-term needs to be done, and how to account for the relative thoracic hypokyphosis and pelvic retroversion that occurs and plan for that in your surgery to ensure that you're adequately correcting these patients. So the benefit of using a system like this is that they take your plan and they bend the rod in their lab. So there's no notches, there's no stress risers. This leads to a stronger rod. You don't have to bend it in the OR, which can take time, can take OR time. And studies have shown that we're not that accurate in reproducing rod bends. And then all of those variables are removed when you use pre-bent rods that are specific to the patient. And the way that this system works is they start with your image, they simulate the case, they give you the implant, and then they follow post-operatively with the scoliosis x-rays to ensure that you achieve the adequate correction. And then it also helps them see how patients are responding to these fusion constructs with pelvic anteversion and thoracic kyphosis. And this kind of displays their pathway, but basically they did not understand the pelvic tilt compensation that was occurring with these rods until they started with their predictive model, okay? And what they've been able to find is that SVA is improved in these patients, the PIL mismatch is improved in these patients, and that they have a stronger rod, right? So, which we would expect, but you can see here that with a rod fracture rate with PSO, without PSO, appears that the rod is stronger. This is what they give you. You send them your plan, or you send them the x-rays, they send you a plan, and then you follow post-op and you can track all their pelvic parameters. NuVasive has a similar model which can be done intraoperatively, where you can drop down where all the pedicles are. They have a rod bender where you can bend it based off of where your pedicle screws are. And then from that, you're able to add lordosis and kyphosis into your rod that will spit out instructions like this. And then hopefully, if you've achieved the adequate correction, you can drop the rod down and be good to go. So in conclusion, surgical planning removes the guesswork of the OR day. It streamlines the OR day, and all of your work is front loaded. So potentially saving you time and cost in the long run.
Is there any questions?
William, I have a question. This is Ian. So my question to you is, where do you see all these things going in the next 10 years based on your review of, how are we going to be planning our surgeries as this technology matures to create the best outcome for patients with deformity?
Well, like I said, I think with the software progressing and the analytics progressing, because we've seen that we can correct patients, but sometimes that doesn't work, right? They still develop proximal and distal failure. And I think as we get smarter, we're going to be able to more accurately predict. And then as those numbers creep up higher and higher, the success rates creep up higher and higher, it's going to be harder to ignore this technology. And I think that, it's going to be, as it becomes easier to incorporate and it becomes more accurate and the outcomes are, demonstrably better, it's going to be hard to ignore it.
Thank you.
That's a great talk, William. So, we had a friendly discussion, myself and Dr. Vanni, about where a correction occurs for a flat back syndrome. We know that, the lower that you do it in the spine, that it has a more beneficial effect on the global alignment. But, if you do a PSO through a previous fusion low down, that certainly has a lot of morbidity. You can get 30 degrees, and comparing getting 30 degrees, let's say at L1, L2, just above the prior fusion, does it make a difference? Dr. Vanni was saying that when he's done that, it's been universally unsuccessful with breakdown above. Any comments either from you or from Dr. Wang or Dr. Lebwal? I see them on the call.
I would just add that, I mean, you're always trying to correct the patient physiologically, and certainly 30 degrees at the thoracolumbar junction is not physiologic, which I think sets us up for future problems down the road. I think whenever possible, you should try to correct it as low down as possible, because that's physiologic.
I don't want to chew into Robbie's time, but that's a great point, Alan. We could have a whole day talk about the locational lordosis, the harmonization of, harmonization of the spine and all that. That's a great talk. Maybe we could have a follow-up on that. It's a very, very complicated topic.
Good morning, everyone. Thank you to William and Aditya for their excellent talks. I'm going to change gears a little bit, and I'll be talking today about survival trends after surgery for spinal metastatic disease. As you can see, this was work that I did while at Sloan Kettering. I have no disclosures personally, but this work was funded in support from the NIH and a core grant. So what I'd like to speak about today is that over the last 2 decades, we know that we've had advances in systemic therapies for cancer. We know from other publications that patients are living longer with cancer overall, which is excellent for us as healthcare providers and humanity. But there's a question of whether this same survival benefit has been conferred to patients requiring surgery for metastatic spinal disease. The paradigm of treatment has really been set in the modern era by the Patchell trial in 2005, and we've really been focused on preservation of ambulation and other elements of quality of life. But are we in fact also helping survival? We hypothesized that with advances in systemic cancer therapy and surgical care, that there would be a temporal trend towards increased survival benefit based on the year that a patient was operated on for spinal metastasis. We did this by looking at data for 1,500 patients who had undergone surgery for high-grade epidural spinal compression, epidural spinal cord compression scale, also known as the Bilski grade 2 or 3, or tumor-related mechanical instability with confirmed disease on final pathology. We then calculated overall survival based on the date of surgery until death or last follow-up for those who were censored. And finally, we analyzed trends using Cox proportional hazards modeling and recursive partitioning analysis. Just to look at the study population, so began with 5,300 spine surgeries performed at Sloan Kettering from 1998 to 2017. These records were hand-screened individually by pathology report, and 3,600 episodes were removed for other primary spinal tumors, washout surgeries, patients where pathology was actually negative for tumor, and degenerative or non-tumor cases, which are still performed there. This left about 1,600 episodes of surgery for pathology-confirmed patients, and we had another 168 patients removed for later surgeries in the same patient or kyphoplasty or biopsy only, and that arrived at the study population. Looking at some of the patient characteristics, we had a 60% male population with average age at 60. This is consistent with what's been reported for patients presenting with metastatic spinal disease. Also, in terms of location, 60% were thoracic, 11% cervical, 25% lumbar, and only 1% sacral. In terms of primary sites, so 75% of the patients could be accounted for with breast, colon, kidney, lung, prostate, and sarcoma primaries. Skin and thyroid also represented, and then a large variety of other primary histologies, about 25%. Accounted for by those. When we analyze the distribution of over time of the primary sites, you can see here in this graph that there's kind of a large increase in 2010 with the arrival of a new surgeon. But when you look at the actual proportions of the primary sites that are most represented, there wasn't a large change over time, except for lung cancer became more prevalent in the later time of the cohort. So I'm going to go through some of the results of the meaningful trends. So for patients with renal cancer, or excuse me, renal primary, the median overall survival for the total cohort over 20 years was a little under a year. There was a 3% improvement in overall survival per year based on the year of operation when looking at this overall cohort. Furthermore, using recursive partitioning analysis, you can look for, was there an inflection point or a year wherein after that year, did you have a substantial improvement in survival for those patients? So for kidney primary, it turned out that 2011 had such an inflection point such that if you were operated on after 2011, the median survival was 1.36 years for those patients versus only 0.78 years for those before. For breast cancer, there was no trend overall based on the year of operation, but there was a split point on RPA in the year of 2016, such that patients operated on after that date had a substantially better overall survival. For lung primary patients, you can see that the overall survival for the cohort is fairly poor. It was only about 0.4 years. However, there has been a 2% improvement in overall survival per year based on the year of operation in these patients. There was no split year, however, on recursive partitioning analysis. This was just a steady increase. And finally, for colon primary patients, there was a 5% improvement in overall survival per year with also no RPA split on further analysis. We also looked at metachronous versus synchronous presentation of disease. So to define those terms, synchronous presentation meaning that a patient is presenting with spinal metastasis as their new cancer diagnosis. So they've never had systemic cancer therapy before treatment for cancer. Whereas metachronous would be, for instance, a patient who's lived with breast cancer for 10 years, who's now presenting with spinal metastasis. So when you look at these two different groups, how did they fare comparatively? So the median overall survival for patients with synchronous disease was substantially above those with metachronous disease, with 0.94 years for patients presenting with new cancer diagnosis and spinal metastasis. For the other cohorts that we analyzed, there were no significant trends noted in their survival, and those cohorts included thyroid, prostate, sarcoma, and skin cancer metastases. When you lump all these patients together in one single cohort, the median overall survival was 0.7 years. And while there was a trend towards improvement over time for the entire cohort, this was not statistically significant. The p-value is 0.12. When you lump all of the primaries together, this correlates with what's been reported in the literature, but the best survival out of these primary sites is breast, and the worst is skin cancer. So to summarize the main findings in this study, so for kidney cancer, breast cancer, lung cancer, and colon cancer, there was a statistically significant improvement in survival over time based on the year of surgery. So that ranged from 40% over the study period to 100% for colon, for instance. Patients presenting with synchronous metastatic disease had improved survival compared to those presenting with metachronous disease. And finally, the improvement in overall survival for the entire cohort did not reach statistical significance, but likely due to the heterogeneity of that study population. So what are the strengths of this study? It's a large patient cohort from a single institution with a high degree of follow-up. The median follow-up time for survivors was 27 months. Most of these patients, once they are plugged in to the cancer center, they follow their either until their death or or furthermore until, as long as possible, let's say. There were uniform surgical indications and treatment strategies over the study period. The NOMS criteria basically been applied since 1998 in a uniform fashion. And although there's obviously been major advances in spinal instrumentation and techniques, the goals and principles behind separation surgery have remained relatively the same. And finally, this study utilizes an analysis of trends over time rather than pooled analysis of patients over a wide time interval. So often when studies are looking at perhaps making an index to predict survival time in these patient populations, they'll pull together data from 15 years of surgery, whereas this study we look specifically year by year to compare trends and help account for advances in systemic therapies. What are the limitations? Well, there's a lead time bias introduced when you measure survival from the date of surgery. Like I talked about, you have a mix of patients who have been living with cancer for many years, or patients presenting with new cancer diagnosis, all mixed into one cohort. So this certainly complicates taking away major conclusions from the study. It's a heterogeneous population of patients with numerous primary histologies undergoing a wide range of systemic therapies. There was lack of classification based on pathologic diagnosis, genetics, and molecular profile, things we know are important, especially in the era of targeted therapies to individual patient survivals. And finally, it's a single center study with outcomes from tertiary, quaternary cancer center, which may not be generalizable to all medical entities. But kind of the most meaningful point to get across, hopefully, is that there are implications to this study. So with the postoperative survival increasing in these patient populations, these data support the need for durable, systemic, and local treatment strategies for patients with spinal metastases, and for outcome studies with emphasis on long-term quality of life and return to work. I think hopefully everyone has seen now patients who are surviving 5 years plus with what were once very dismal cancer diagnoses, and it's becoming increasingly important to give them durable surgical constructs that help keep them ambulatory and with meaningful outcomes. Of course, future studies will focus more in depth on primary site-specific analysis and cohort by cohort, but overall, the goal of this study was to show that in fact, there are patients who are living longer with metastatic spinal disease. This was published in September in the Journal of Neurosurgery. And hopefully I made up some time. I'll gladly take any questions.
Nice work, Robbie. I think it's valuable, especially because, when we go to our oncologists and say, how long do you think this patient's going to live? They often overestimate and or don't know. And, you could go to this database and get a good idea of what we see as surgeons, patients with metastatic spinal disease with a certain histology, what's their, overall prognosis. I was just a little bit concerned because, you said that, Sloan Kettering has a very uniform way of dealing with these patients. And I imagine even at Sloan Kettering, that must be hard. A lot of the times it's, your decision-making is based a little bit on gestalt of where this patient is, their bone density, how they look, their overall disease burden. And it was kind of funny that you pointed out that when you looked over the 20 years, that the biggest influence on volume was the accrual of another surgeon. And if you think that if your intake is uniform, simply adding another surgeon shouldn't affect that decision making. And it seems like it has. So how would you respond to that?
So in that year also, interestingly, Sloan added multiple other sites. They added about 6 hospital sites. And so the explanation when we talked about that, obviously, and the explanation was that the catchment had increased also substantially. So, but yeah, it's all these temporal trends, they introduce all these biases, and certainly it's not as perfect as perhaps I stated. It's certainly a limitation here, but the explanation was that they substantially increased their referral base effectively as well.
Hey, Robbie, it's Ashish. Just had a quick question for you. Just from someone who's not necessarily as familiar with spinal oncology. We've had a few patients that we've, seen on the spine service who have widely systemic disease, who, we get oncology to, tell us, oh, what's their overall survival. And, sometimes they're not very specific. And sometimes they say, oh, something like 8 months. Is there a cutoff that you've identified with your RPA analysis on types of tumors that you say, okay, well, it's worth it to operate on this patient because their survival is going to be X, Y, and Z, or their functional status is definitely going to improve. How do you see this data set being used, to kind of predict one, functional outcomes, and two, prognostic outcomes, because I think that that's like a huge thing that we don't understand yet. And I think that with a data set of 1,500 patients, hopefully you should be able to find out at least some predictive and some concrete, data sets, I guess,
That's a great question, Ashish. I think that the temptation to make broad conclusions from this specific study is there, and I don't think that this offers that sort of predictive data. Definitely could be utilized for that. I think ironically, the message I'm trying to get across is that it's very hard to predict based on past data sets and systemic therapies to make future predictions for these patients. But one thing that is important is often we as surgeons ask the oncologist to make predictions about survival. And there are two useful things to take away. I think one is a question you can ask the oncologist is, does this patient have further systemic therapies available? So for instance, if you have a patient with breast cancer who the oncologist tells you, listen, I've tried everything, there's not even experimental therapies available to this patient, then you know that their survival is unlikely to be good. Because even if you perform a surgery to keep them ambulatory, their systemic disease is probably going to claim them, pretty shortly. Whereas if you have a patient who the oncologist says, they have renal cell cancer and they've never tried ipi-nivo or a checkpoint inhibitor, those are therapies that, could drastically increase their survival. So I think that becomes a more meaningful question than asking sometimes the oncologist to predict, months. That's one thing. The other piece of the puzzle is that ultimately these surgeries are palliative. And so if you have a patient with horrible debilitating pain from mechanical instability, even if they're only, God forbid, they're only going to live 6 more months, you can still have a meaningful impact, hopefully with a relatively small surgery, to take away those symptoms and give them quality of life. So it's really complicated. I hope I haven't oversimplified anything. Thank you all very much.
Our next presenter.
We should have neuropathology ready now.
Okay.
Sounds like you have two phones connected in the same spot. It's an echo.
Yeah. Let's share screen. Perfect. Can everybody see my screen?
Yes, we can see it.
Okay. Is Dr. Sayed available? Or Dr. Kultikin? Okay. Anyway, so we'll be given the neuropathology conference for the month of January. Special thanks to Dr. Kultikin, Dr. Sayed for always giving of their time to help us with that. We have 4 straightforward cases today. So first case, I don't know.
Sorry, Roberto, you want us to call them? You reminded them? They know?
Yeah. I talked to them yesterday, so.
Okay, all right.
I saw Dr. Saad earlier on the call or on the Zoom, so he should be here.
Yeah, maybe he thought it was 7 a.m. I'm not sure. Anyway, let's continue. So first case, let's see, maybe Silva, are you around?
Yeah, I'm here.
Okay, perfect. So we have a 59-year-old female with a 3-month history of progressive right lower extremity weakness. She also complains of some mild thoracic pain. She denies any upper extremity symptoms, and of past medical history, she has rheumatoid arthritis. Okay, so any other things you might want to know about a patient with a 3-month history of progressive right lower extremity weakness?
Like her neuro exam, is she like what's her strength like?
Okay, but even before a physical exam, just review systems, any other things you might want to know about the history.
Any urinary symptoms, gait difficulties?
Perfect. Exactly. So a patient presents with leg symptoms, you want to know if the patient has any urinary bowel dysfunction. That's very important. Also, if the patient has any balance, walking issues, which will point out having some myelopathic symptoms. And yes, the patient was having some problems with walking. She was using a wheel, a roller. And also other things you can want to ask if the patient had any specific dermatological distributions. You want to know if it's in the distribution of a L5, S1, or if it's mostly thoracic. And in this patient, there was no specific distribution. Also, something important to know is the patient had any prior imaging. You want to have something to compare of with images. Also, rheumatoid arthritis. Do you know any important things to know related to spine pathologies and rheumatoid arthritis, Silva?
Maybe if they've been on long-term steroids or anything to affect their bone quality.
Yeah, that's also important. You can have patients when treated with corticosteroids for long periods of time, they can have decreased bone mineral density. But they also have risk of developing some like cervical pathology. A large percentage of them can have atlantoaxial instability. They can have basilar invagination, and they can have subaxial subluxation. This is not the case in our case, but something to have in your back of your mind whenever you see a patient with rheumatoid arthritis. So here's the physical exam. Basically, the patient has right lower extremity weakness from the IP down, and some hyperreflexia on the right patellar. So what kind of imaging will you want to this patient? Patient with leg pain, weakness from the IP down, and some early myelopathic signs. Will you want with no upper extremity symptoms?
Yeah, I would start with thoracic and lumbar. I'm thinking lower thoracic or upper lumbar pathology.
Good. So thoracic MR. Perfect. What do you see?
Looks like a T2 hypointense and mildly contrast enhancing, maybe lesion at the level of looks like so contrast enhancing looks like a mid thoracic, lower thoracic lesion, posterior to the cord. I would say looks extradural. But I have to go back. If you go back to T2.
Look at the
actually, it looks. I would say intradural and extramedullary lesion.
Okay. Perfect. So basically, an homogeneously enhancing intradural extramedullary lesion at the level of T18-9 with core compression. Very good. Any additional workup in patient with thoracic tumor? Anything else you want to know?
We get imaging of the rest of the neuroaxis. See if there are any other lesions.
What else?
Maybe just systemic imaging to look for other malignancy.
Yeah, although rare, right? If the patient has a history of cancer, which is not the case, you can do a metastatic workup. Also, you can ask if there's any history of similar tumors in the family, especially patients with NF2. They have a propensity for developing meningiomas, schwannomas, and Also, you can get CT to evaluate for calcifications too. Okay. So this is a CT. What do you see?
So looks slightly dense on CT. She's looks like pretty bad osteoporosis as well.
Yeah, very good. So it looks like it's calcified. Very good. Okay. So what's your differential?
So I think ependymoma, schwannoma, less likely meningioma, and then metastasis we also talked about.
Okay. So for intradural extramedullary, what's your top differential? Top two?
Ependymoma and schwannoma.
So schwannoma for sure. How about meningioma, right? Meningioma. Is ependymoma extramedullary or intermedullary?
Yeah, intramedullary. Yeah.
Okay. So your top diagnosis is, as you said, it's going to be meningioma or schwannoma, and then less likely neurofibroma metastasis. Okay. Okay. So you have this patient with progressive weakness, large lesion in the thoracic region. How will you treat it?
So yeah, she's symptomatic. You also need tissue, so it needs surgery. It's all posterior, the cord. So I think laminectomy at that level. I'd have to go back to the imaging, but yeah, 1 or 2 level to get whatever is needed to get all the lesion, and yeah.
Right. So you will go after, try to get the whole resection, right? No, not just like a biopsy.
Correct. Yeah.
Okay. And any other like things you can do intraoperatively to help you with the resection? And then it's a spine thoracic case, big tumor. You want to make sure you don't injure the patient. What else can you use intraoperatively?
So you want neuromonitoring to make sure.
Perfect. Exactly. Very good. How about will you need instrumentation in this case, or?
I don't think so. If you're just doing a 1 or 2 level LAMI in the thoracic spine, as long as you don't have to go too far out to affect the joints, you'd be okay. You have the ribs to support.
Very good. And then adjuvant treatment depends on that pathology. Perfect. Excellent. Good job. Let's see. I don't know. Is Dr. Sayat here or Saad? I don't.
I just texted Hume, who is texting him. Why don't you be the pathologist in the interim?
Sure. Yeah, let's do that. So basically here, you see this areas of like focal calcifications, which were basically expected with the CT that we just showed. And also here on the middle part, you see this like whorls. They basically call it's a better picture here. Meningotial whorls is basically characteristics of meningiomas. What else? Here you see a little bit more of it, of characteristic meningotial whorls.
If you go back to the high power view, and if you look at the nucleus, there's sometimes the haloing that you see in the nucleus that you see in a number of those. I think that they're called, pseudonuclear haloing or something like that. That can be characteristic of meningioma. There doesn't look like there's any mitotic figures. And I must have missed, did you show a CT? I only saw MRI scans. Because you were asking about, you were asking about, other imaging, whether you should image the neuroaxis, if something looks like an obvious meningioma, which this does, and you only had one other test that you could order, I would say CT was probably the most valuable in terms of diagnosis, and also telling you how difficult the surgery is going to be, because if it's calcified and like a rock, and especially if it's ventrolateral, it's going to be a much more difficult surgery than if it's not calcified.
Excellent. Perfect. Okay. So basically, as Dr. Levy was alluding to, the diagnosis in this case is a spinal meningioma. Peak age is between 40 to 70 years. There's a female to male ratio of 4:1. 82%.
I'm sorry, 1 second, Robert. Sorry, Assad just texted me that he does not have the link to the Zoom. I'm driving. Can somebody email him the link? Ignacio, are you there? He doesn't have the Zoom link.
I'm right here. What's the name, doctor?
Ali Saad. S-A-A-D.
Got it.
What?
I'll
doing
take care of it, doctor. Yes, sir.
Okay.
Ingrid here. I'll send it. I'll send it again.
Got it. Thank you, Ingrid.
I never received a link or invitation or anything, by the way. Can you guys hear me?
Yes.
Yeah, no, we apologize for that. We'll make sure that that doesn't happen again.
Okay.
You guys are in the first case?
Yes, sir.
All right. So this is the meningioma. So at low magnification, you can see so many Samoma bodies. And this would be characterized as Schwannomatosis meningioma, which is a grade 1, doesn't have any impact on the prognosis. Next slide, please. And this is higher magnification to show you Samoma bodies. They're basically, as opposed to dystrophic calcification or ossification, they are laminar accumulation of calcium, which results in this lamellated spherical structures. Next slide. And higher magnification in the top center, you can see a pseudo-inclusion, and it has the same color as the cytoplasm, and that's basically, it's called pseudo-inclusion because it is an invagination of the cytoplasm into the nucleus rather than a true inclusion of the nucleus. And also, if you look at the nuclei, there is minimal variability in size and shape, so there is no atypia or pleomorphism. So there are no high-grade features. Next slide. And Ki-67 is low, like 1 to 2%. So this is a Schwannomatosis meningioma, WHO grade 1.
Thank you. So as we were talking, so peak age 40 to 70 years, female to male ratio is 4:1. 80% of the time it's localized in the thoracic region and 15 in the cervical. 9% are purely intradural, but around 5 can be intra and extradural. The majority of the patients are symptomatic. 90% of them present with long tract signs, about half of them with sphincter deficit, and 40% with early myelopathic signs. The treatment consists of complete resection, but there's over a 7% recurrence rate after 6 years. As we talk in the pathology, they often contain any meningothelial whorls. They have a eosinophilic cytoplasm, sorry. They contain some monobodies, and they can be calcified, although they only account for 1 to 5% of all spinal meningiomas. And the most common type is Schwannomatosis type, as in this case. So this article from the Acta Neurochirurgica presents 84 spinal meningiomas that were followed up for around 32 months. During this period, there was a 5% tumor recurrence rate. However, when they were analyzed as subgroups, depending on the follow-up, in patients that had a follow-up of more than 6 years, tumor recurrence rate was seen in 44% of the patients, which is seen here on the table on the right. And the mean age was 51 in those patients. So as in our case, if the patients are diagnosed with a spinal meningioma early on, we have to follow them for several years because they might end up having a recurrence after 6 years. Okay, so next case number 2. Let's see, Big Nesh, are you around?
Yep, I'm here.
Okay, perfect. So 52-year-old female patient, past medical history of lupus, anticoagulant, and previous stroke on Eliquis, refer for a growing skull lesion. Patient complains of some mild right temporal headaches, but denies any weakness or sensory deficit. Past medical history, as mentioned before, lupus, anticoagulant, previous stroke, couple of surgeries. The patient is a smoker. Just from the history, what other things do you want to know?
I guess if she has any history of cancer anywhere else, any apart, from the headaches, any other neurological deficits or
Exactly. Very good. And how about of the skull lesion? What do you want to know?
I guess like is it hard and immobile on the skull, or is it more soft? Is it is it mobile?
I mean, some characteristics of it. So as you mentioned before, you want to know if the patient had any previous deficit after the stroke. Before seeing the patient, you want to know if there's any weakness, but the patient obviously resolved after 1 week after her stroke. Also, if she had any history of a bump in her head before, to see if it has progressed or if this is something new. Also, you want to know if the patient had any previous imaging, because you want to compare the new image with the previous one. And in her case, she did have an MRI 1 month prior because she was having headaches. MRI was negative. That's something important to have in this case. And as you mentioned before, if there's any history of cancer, if there was any workup done, the patient had a metastatic workup done, which was negative. And also it's very important in patients that present with skull lesions, if they had any other bony lesions or continuous manifestations, because this is seen in patients that had Langerhans histiocytosis, as we were going to mention a little bit later. Physical exam of the patient, that's basically a normal exam. Let's go to imaging. So, Vignesh, what do you see?
So it looks like, at least on MRI scan, it looks like she's got sort of a intradural, or I guess maybe a dural-based, dural-based lesion that is contrast enhancing underneath the calvarium, extraaxial. That sort of has some you can see some mild hyperostosis of the overlying bone.
Okay.
Yeah.
Okay, very good. So basically, it's a ability enhancing. You mentioned intradiploic lesion on the right parietal bone, with some erosion of the inner and outer tables. And there's also some smooth dural thickening. You can see on the right parietal region too, with some enhancement there. Any additional imaging with a bony lesion you want to have?
I think with bony lesions, I think a CT would be useful.
Very good, excellent. So CT scan. What do you see here?
Looks like a lytic lesion within the calvarium.
Okay, and very important. Do you see any sclerotic margins in here or not?
Not particularly, no.
Excellent. It's very good. Very good. Very important. So what's your differential then?
I guess differential for calvareal bony lesions, you could especially the intradiploic, you could do you could think of, I guess, like osteoma, epidermoid cyst, maybe osteosarcoma, meningioma. I guess meningiomas rarely can I guess present within the bone, and then meningioma, like epidermoid cyst, something like that.
Exactly. So you mentioned a couple of them. So Langerhans histiocytosis, or basically eosinophilic granuloma, if it's just a single lesion, usually presents as non-sclerotic lesion. Epidermoid, as you mentioned, it's basically a scalp border with sclerotic rim. Metastasis, hemangioma, which usually presents as a honeycomb or sunburst pattern. Osteoma, which is basically just a highly dense lesion. Multiple myeloma, meningioma. You mentioned a couple of them. Very good. How will you treat this patient? Basically, a skull lesion was not here a month before. Patient having a little bit of pain.
Sure. I think given the pain and the need to obtain pathology, I think probably be most amenable to like a total resection with just if you're able to drill margins around the bony tumor and then cover it with a a mesh plate and then just send the tumor for pathology. That would
Okay. How about the Dura was enhancing? Would you send some of the Dura too?
I think so. Yeah, I think if you could at least resect the underlying enhancing Dura, replace it with Duragen, and then put a mesh over it. Yeah.
Excellent. Exactly what they did. So basically, they did a biparallel craniotomy for resection of that lesion, send it to pathology, and also resection of the adjacent Dura. And adjuvant treatment depends on what the pathology is. Very good.
Okay, so this is the lesion. And you can see the sharp interface with the adjacent bone. There is minimal infiltration within the bone, but it's not that dramatic. And the lesion appears to be solid with no cystic degeneration. Higher, next slide, please. And so this is intermediate power, and you can see that the lesion is composed of mostly mononuclear inflammatory cells. And next slide. And the larger cells where the eosinophilic finely granular cytoplasm are eosinophils. So we have a lesion that is composed of eosinophils and some different cells that are in the background. And next slide. So this is a better, we flip the condenser, we place some optics, and we can enhance the granularity of the eosinophils. So here you can appreciate the abundant number of eosinophils within this lesion. Next slide. And in the right above the center of the field, you see a coffee bean appearance of a nucleus, literally a little bit above the center of the field. Coffee, yeah, to the opposite side, yeah, no, keep moving. Opposite side. Go to the center. Yeah, you passed it. No, you're moving too fast. Move up a little bit. A little bit. Yeah, this one. So you see this nucleus has a line in the center resembling a coffee bean. So coffee bean, we use them a lot when you do a frozen section. And once we see them and we see eosinophils in the background, we're comfortable calling it eosinophilic granuloma or Langerhans cell histiocytosis. Next slide. Luckily nowadays, we have very good immunohistochemistry stains that we can use to confirm the diagnosis. One of them is CD1A, which will stain not the eosinophils, but the cells with the coffee bean appearance in the background. And next slide. The most sensitive and specific stain that is commercially available is Langerhans. And this one is very easy to remember because it's Langerhans histiocytosis. And it stains also the larger mononuclear coffee bean cells. So next slide. I think this was the last one. Okay, yeah. So this is an example of Langerhans cell histiocytosis.
Okay, thank you. So basically 17% of the patients are 20 years or younger, but the age range is from 18 months to 49 years. 90% sent with a tender enlarging skull lesion, and blood tests are usually normal. The most common locations are the parietal lobe, parietal bone, followed by the frontal bone. Imaging characteristics, especially in skull X-ray, they ask this on the boards all the time. It's basically an oval, non-sclerotic skull lesion with defined margins involving the inner and outer tables with essential bone density. And CT is basically looks pretty similar. The treatment is usually total excision, but there's a 31% recurrence rate in 8 years. In pathology, as we already mentioned, numerous histocytes and eosinophils. Dural involvement is pretty rare, and they stain positive for CD1, Langerhans, and S200. And interesting, most cases harbor a BRAF mutation. I found this paper which talks about the optimal treatment for adults with Langerhans cells histiocytosis. And basically, they look at 58 adult patients with bone lesions. And interesting, they found out that 43% of the patients in this study had other sites of disease, which include the skin, lung, and pituitary. And the incidence of diabetes insipidus was 30%, which is pretty high. So this is something to have in mind when you're evaluating patients with Langerhans. Again, as we mentioned before, the recurrence for this disease is pretty high. This series was 38%. And although they agree that for single lesions, the treatment of choice is total excision, there are also systematic therapies for patients with multiple lesions. They compare different chemotherapy regimens, which included beamblasting and prednisone, which is usually used for pediatric patients. But this one had the highest relapse rate, which was 84%. They compare it to cytarabine, which is used for leukemias and other type of blood diseases, and this combination had the lowest relapse. So there's something to have in mind in patients with systemic Langerhans. Okay, next case 3. Let's see, is Eva around? No?
Yeah, I'm here.
Okay, perfect. So 64-year-old female with a 4-month history of progressive left hip and leg pain. She had a fall around that same time period, and she tried some conservative management, but that failed. She denies any weakness or any sensory deficits. So patient with, again, left hip and leg pain, what are the things you want to know about her symptoms?
Any other like weakness? Does she have any back pain? Is the pain in the dermatomal distribution?
Exactly.
Any bowel or bladder issues?
Exactly. It's basically the same. So you want to know if there's any dermatomal distribution to try to localize, her symptoms. But in her case, it was kind of patchy. She did not have any urinary bowel dysfunction, and she did not have any prior imaging to compare to. Physical exam is basically normal. She was full strength, no sensory deficit, and no long tract signs. So this is her imaging. What do you see, Eva?
So it looks like on T2 there's a lesion near the conus. Do you have it looks intradural, extramedullary? Do you have?
Yeah,
Sorry,
so this
intradural,
is the contrast scan. It's not exactly from this patient, has some problems, but looks very similar to this one. So
I see. Okay. So yeah, it looks like it's an intradural intramedullary lesion. It's at the conus. It's contrast enhancing. It's differential, includes a myxopapillary ependymoma.
What else?
Schwannoma. It could be.
Very good. So intradural extramedullary with heterogeneous enhancement, as you said. Any additional workup with this kind of lesions? What do you think?
Metastatic workup.
Yeah, although very rare. I mean, you can, if the patient has history of cancer, you can do, but this is not the case. And as mentioned before, patients with this type of tumors, you can always ask for family history, as NF2 it's associated with multiple, with meningiomas, Traunomas, neurofibromas. Very good. And you already said the differential diagnosis is going to be Schwannoma, neurofibroma, myxopapillary ependymoma, metastasis. But those are the top ones. So how will you treat this patient? Young patient with a large lumbar lesion with persistent pain on her leg, although the patient is not weak. How will you treat her?
Yeah, I would resect it and then send it for pathology. You could do laminectomy at that level, and if you just do a lami, I don't think you'd have to fuse them. So
yeah, lami resection. Any things you would do intraoperatively to make sure you do a safe resection, especially in this case?
Yeah, so we would do a neuromonitoring, have a patient on a Jackson table.
So SSCPs, MEPs, and you can use intraoperative nerve stimulation to make sure you don't injure a nerve. Perfect. Excellent. Very good.
Okay. So Roberto, do you mind if I share my screen so I can use my arrow?
Yeah, of course.
Okay, let's do that. Okay, can you guys see my screen?
Yes.
The amount of details about like.
Okay, so this is the tumor. At low magnification, it's a solid tumor in this particular area. At low magnification, you can appreciate the presence of what we call a plexiform or nodular growth pattern. In younger people, when we see plexiform growth pattern in a neurofibroma or a schwannoma, this one is a schwannoma, we always think of neurofibromatosis, but I don't think this is the case in this particular case. Another hallmark feature of schwannoma is the so-called Verroquet body. So Verroquet body basically is palisading of the cells around a hypocellular or acellular area, just like in this particular example. In other areas of the tumor, the tumor was very cystic, and we think these cystic are actually degeneration of the tumor due to rapid growth or compression within its own anatomic location. Now, how do we know this is a schwannoma and not a neurofibroma? This is the neurofilament. Neurofilament stains the axons. Remember that schwannoma is a nerve sheath tumor, and therefore it arises from the periphery of the nerve, does not involve the nerve itself, and therefore you shouldn't expect to see axons within a schwannoma. However, in a neurofibroma, which is a tumor of the nerve itself, you would expect to see entrapped axons within the tumor. So here we have a neurofilament, and this is the tumor. You don't see any neurofilament at all within the tumor. So this is a supportive evidence that this is indeed a tumor of the periphery of the nerve and not of the nerve itself. At the periphery, you can see some neurofilament positivity, and this is a little fragment of the nerve from which the tumor arose. This is a low magnification of the same image. Another stain that we use is SOX10, which is a stain for every single tissue that derived from neural crest, whether it's melanoma or schwannoma or anything. So this one just tells us this is a neural process. So this is a schwannoma, WHL grade 1 with cystic degeneration.
Thank you. Okay, so spinal traunomas, they're benign slow-growing tumors. They're derived from obviously Schwann cells, especially from neural crest derivation. Mostly arise sporadically, but they can be associated with NF2. The majority are intradural, about 8 to 32% can be extradural, and from 1 to almost 20% are a combination. They usually present with radicular pain, and 75% derive from the dorsal sensory rootlets. and the recurrence is very rare after complete resection. And pathology, as we already mentioned, they're often encapsulated. They have alternating areas of hypercellular and myxoid regions called Antoni A and Antoni B. And they have the presence of vertical bodies, which is basically some nuclear palisading, as it was mentioned. They stain positive for S100, leucine 7, type 4 collagen, and C34. And as it was already presented, this always comes up on the board every year. Vertebrate bodies, this is how they look like too. Another slide, and it's associated with spinal traunomas, or traunomas in general.
Roberto, you said on that last slide that it's associated with NF2. I can't think of a case of a schwannoma that we've removed from a patient with NF2. I mean, we do see a bunch of patients with schwannomatosis, and that's clear cut. Those are mostly schwannomas. I don't know if you have anything there about the genetics of schwannomatosis, which we seem to be seeing more and more frequently.
Interesting. I did not include schwannomatosis. That's a great point. But NF2 is mostly in general associated with meningiomas and schwannomas, especially in the supratentorial and posterior fossa. So that's what I'm referring to here. But you're right. You're correct. Yeah.
Yeah. So schwannomatosis are characterized since you brought up the genetic makeup, schwannomatosis are characterized by loss of INI1, which is the SMARCB1 gene. If this rings a bell, you are correct, because the SMARCB1 gene, or INI1, which is the gene product protein, is lost in ATRT, atypical teratoid rhabdoid tumor. So it's the same gene. So this is one of the pitfalls in pathology, because schwannomatosis may look like rhabdoid actually under the microscope, although they are low grade, they're grade 1, and they can lose their INI1 immunostaining, which overlap with rhabdoid tumor. This is the only genetic abnormality that has been consistently described in schwannomatosis.
Interesting. Thank you. Okay. So basically, this is a study that looked at surgical outcomes and factors related to postoperative motor deficit after surgery in 244 spinal traunomas. Interesting, they present a schematic illustration of the Eden classification, which basically classifies the traunoma based on the compartment which occupies, if it's intradural, extradural, paravertebral, or even foraminal. Basically, they show that after following 244 patients, patients that developed postoperative motor deficits, not surprisingly, had preoperative early myelopathic signs with gait disturbances and were weak prior to surgery. As it's been demonstrated in other like spinal tumors or spinal lesions, patients that have preoperative deficits usually do worse than patients that do not. And this, it's kind of related to our case. The patient did not have any motor deficit, but the patient had a significant, large, lumbar lesion and pain. And there's some talk always of when to do surgery in these patients. But it's important to keep in mind that if you wait too long for patients to develop weakness, usually those patients don't do well after surgery. Okay, so last case. Sumedh, are you around?
Yep, yeah, I'm here.
Okay, perfect. So 52-year-old male patient with a 1-year history of recurrent dissociative episodes. They usually last between 15 to 30 seconds, and he describes them as being unaware and frequently are followed by a period of confusion. Sometimes they're preceded by the smell of pollen. Okay, so Sumedh, what other things do you want to know about the history patient with episodes of being unaware?
Yeah. For this gentleman, has he had any seizure history in the past? Has he? Yeah, that's like kind of what the based on this history, looking maybe towards some like seizure, epilepsy kind of picture. What his? Yeah.
Yeah, very good. So basically, any history of seizures, no prior history, and although if the patient had any treatment for this episodes, and he was followed by a neurologist who was treating him with Keppra, increased the dose, changed medications, that did not help. Physical exam, basically normal exam, and this is the images. Real difficult, not that obvious. Maybe on the contrast one, you can see a little bit better.
Yeah, on that right anterior temporal lobe, it looks like there's contrast enhancing, like a circular lesion. Is that the scan on the right?
That's a flare.
Flare. Okay.
Yeah. So some flare abnormality right in the anterior temporal lobe. Does this look intraaxial or extraaxial?
It looks intraaxial to me on the.
Very good. Okay. So basically just a solid cystic cortical base intraaxial mass with some mild enhancement. Very good. I mean, any additional workup, I don't think in this case matter. You can do some functional MRI, some epilepsy workup, which he already had. So what's your differential?
Yeah, differential for this. I'm sorry. I would say like it could be like a tumor, a metastasis, for example. It doesn't look like it's like a cystic mass. So I mean, it could be. I want to say like there's no real flare enhancement, so it's like unlikely to be like an abscess. Yeah, I would say like either like a tumor, could be like a cavernoma. Just looking at kind of like it looked like there was a, like, I don't want to say popcorny appearance, but it looked like there kind of looked like I guess like based off your face, it's unlikely to be a cavernoma. So
you were heading in the right direction. What type of tumor causes seizures? You see them very often in UMH.
Like a glioma.
Yeah, right. So first is you're right. It could be like low-grade glioma, less likely high-grade glioma, right? What other type of tumors, intraaxial tumors, present with seizures in the younger patients? Do you remember any of them?
The seizure in younger patients.
I'll help you. PXA, right? PXA, DNET, ganglioma. Okay, so that's going to be our top differential. Okay, so patient is clearly symptomatic, failed conservative management, failed medications, has a lesion. How would you treat this patient?
Yeah, I think justifies, if he's failed medical management and he has a resectable lesion, I think surgical intervention is appropriate. So a lesionectomy for this.
Very good. So temporal crani resection of the lesion. You can use neuroamputation. Very good. Excellent.
All right. Okay, so this is a pleomorphic xanthoastrocytoma, and I'm going to show you why it's called the pleomorphic xanthoastrocytoma. I'm sure you guys know that xantho means lipid. So pleomorphic, meaning the tumor cells have significant atypia and pleomorphism with some bizarre cells like this one and that one. And here you can see a cell where the cytoplasm is kind of finely vacuolated because of the accumulation of fat. So in this single field, you have pleomorphic cells and some xanthomatous cells. In other areas, this is at the junction between the tumor and the relatively spared adjacent brain. You can see there is increased cellularity, but it's not solid growth like the slide before. And you can still appreciate the presence of these pleomorphic, bizarre-looking cells. Back to the tumor, this is a better example of the xanthomatous cell or cell that where the cytoplasm is loaded with fat. You can see the fat globules. Some of them are large, some of them are small, and these are the pleomorphic cells. Another feature of the pleomorphic xanthoastrocytoma, and not only of pleomorphic xanthoastrocytoma, actually of any slow growing process in the central nervous system, whether it's neoplastic or non-neoplastic, is that these processes are associated with increased number of eosinophilic granular bodies, EGBs for short, and Rosenthal fibers. And pleomorphic xanthoastrocytoma is not an exception. So this is the tumor. And here you have this large eosinophilic blob, which is the EGB. In other area, you can appreciate the presence of Rosenthal fiber, which is described as a corkscrew, hyalinized, pinkish accumulation of alpha-beta crystallin. Why is astrocytoma? Because it's diffusely positive for GFAP. And Ki67 is very low as expected in a grade 2 tumor. It's around 2 to 3%. So this is an example of a pleomorphic xanthoastrocytoma WHO grade 2.
Thank you.
Hey, Ali, Morkos here. Very often, as you know, during frozen section, PXA can be confused with GBM.
Correct.
Is I guess any hints how to avoid that, or that's just the nature of the pleomorphism that is confusing in frozen?
Exactly. The frozen is never perfect because, as you know, the artifact and the freezing artifact. So once we see, we rely a lot on the radiology. So we sometimes suggest the possibility of PXA if it is cystic and superficial. But in the majority of the cases, it is very difficult to be certain whether it's a glioblastoma or PXA or frozen.
Okay, thanks.
Yeah.
Okay, so PXA, usually low-grade glioma, who grade 2. 90% of them are supratentorial and have a predilection for the temporal lobes. Most common seen in children or young adults. A mural nodule with cystic components is seen on the 25% of the cases. The meninges are involved in less than 67%. They usually present with seizures, and treatment is gross total resection. As mentioned before, WHO grade 2, but can be WHO grade 3 if they have a high mitotic index or the presence of necrosis. There's a presence of giant multinucleated astrocytes, and they have lipid-laden cells, as I would mention on the pathology slides. They stain positive for GFAP, and they have abundant reticulin fibers. This paper talks about the natural history and long-term follow-up for PXAs. And something that comes up always on the boards is the presence of BRAF mutation. PXAs, usually around 70% of the cases have a BRAF mutation. And the overall survival, although it depends on a lot of factors, in general, patients that have a BRAF mutation on long-term follow-up do better than patients that have not this mutation. This is in this study seen with at least 15 to 20 years of follow-up. Also interesting, now BRAF is a target for therapy. There's this small study looking at gliomas with BRAF mutation using different medications to target the BRAF. And interesting, patients with PXAs are the ones who benefit the most of this kind of treatment. They mentioned here that 57% of the patients had a clinical benefit of systemic treatment with BRAF inhibition. Although this is a small number and a very early study, this is something that maybe in the future will have a role in the treatment of gliomas that have this mutation.
So the best way to remember it for all practical purposes about BRAF, all tumors, the majority of tumors that are cystic have BRAF abnormality, whether it's ganglioglioma, pilocytic astrocytoma, pleomorphic xanthoastrocytoma. They all share similar imaging findings, and they're all associated with abnormalities of BRAF mutation.
Oh, that's interesting. Thank you, Dr. Sad.
Yeah.
Okay, very good. So that's it. Thank you, everyone.
Thank you, everybody. Have a good day.